All right, so after that interesting Zoom event, we are going to be doing this talk via YouTube video. So, all right, let's get started. So this talk is kind of a preview or a prepper, if you will, for the talk I'll be doing on a self-entropic broadening theory next week. This talk kind of will delve into kind of the stories that psychedelic science has created around how psychedelics and psychosis are related, which really, I think these stories basically haven't gotten enough attention and are important for understanding the state of psychedelic science in relation to psychosis today. So I think one thing to think about that I mentioned in all my talks is that all models to some extent are wrong, but some are useful. So you think about the actual world and how there's a bunch of data out there. There's never going to be a theory or a model that perfectly predicts everything, or in psychology and neuroscience in general. There aren't any hard, fast rules. But we can make general models that are useful, that can tell us about how the world typically sort of behaves. So the idea of psychedelics and psychosis is some people say psychedelics are psychotoma mimics, or they're mimicking psychosis, they're a model of psychosis. It's important to think about how is this model useful, or is it useful? So that's something I think we need to keep in the back of our mind as we go through this discussion of the history of psychedelics and psychosis. So I think one thing to kind of point out that's important is that when we think about psychedelics and psychosis, there's generally sort of two different flavors that people take these potential connections between these two very different experiences in a lot of ways. So one way people often compare psychedelics and psychosis is that they say that psychedelics can produce some drug effects that are similar to psychosis. So in the 1950s, there's quite a bit of sort of press coverage about psychiatrists giving things like LSD to people to create symptoms of psychosis temporarily, maybe so that, somebody who's a psychiatric nurse could have more insight into the experiences their patients were having. The other sort of idea that often comes up for people is that psychedelics are somehow causing psychosis. This is a different sort of issue, but you can think of a few famous examples. So, for example, Brian Wilson, he was in the Beach Boys, and he claims, or at least there's a lot of press coverage suggesting that he developed schizoaffective disorder partially from LSD use. Syd Barrett, who was a member of Pink Floyd, is also another example of somebody who, at least, in sort of popular culture, that we think of having developed schizophrenia from psychedelic use. So it's just important to remember that mimicking and inducing aren't really the same things. So by the same logic, you might say, oh, if you give somebody a stimulant, if you give somebody amphetamine, a neurotypical person, they might become a little hyperactive. They might move around more. Is it mimicking ADHD? Maybe, kind of, you could say, looking at the surface, just looking at behavior. Could you then say that stimulants cause ADHD? And that people with ADHD should not use stimulants? So something like Adderall is often a treatment for ADHD. So that's kind of showing, even though this is a very sort of simplistic model, if you will, that you cannot simply say that mimicking equals inducing. But as we look back at these two arguments that psychedelics somehow are mimicking psychosis or they're inducing it, we need to consider what evidence there is for it. Because it's something that, you hear about clinical trials, people with a history of schizophrenia being excluded. You hear about psychedelics somehow comparing to psychosis in a lot of the theoretical models, what sort of evidence do we have for these connections? And more importantly, how did we get to this point where people keep making these connections, even though maybe there hasn't been that much empirical research into these questions in recent years? So I think a big thing to remember is where psychedelic science and psychedelic psychiatry kind of started. So this was in the middle of the 20th century. And during this time, psychoanalytic theory, so that's like Freud and psychoanalysis, it's lying on a couch and, just letting your mind wander and talk about your feelings. It's that kind of mental health treatment. During this time, people had tried to sort of treat psychosis with this kind of psychoanalytic informed, I guess, treatment. So just people talking. And, people with schizophrenia, they weren't necessarily getting better from this. You can see here's a quote from 1954. For many years, we assumed that most mental illnesses were functional disorders brought on by emotional stresses and strains, and the way the patient was treated in childhood. But after 50 years of this approach, the hospitals are as full of mental health patients as they ever were. They occupy as many beds as all physical patients combined and cost the country $1 billion a year. So this is kind of saying, even though psychoanalysis, it did say some important things about, childhood being important and our relationships with our parents being important for shaping mental health conditions, its method of treating people, especially for schizophrenia, wasn't working out so well. So then comes along psychedelics. And these really shook up psychiatry at the time because it kind of created this idea that, maybe that biology is important for, psychosis at least. So this is in the same article as the one that I previously quoted. And it says, lightly, however, we have been changing our minds about the most prevalent mental disease, schizophrenia. Not really the most prevalent, but we'll go with it. New evidence is bringing us back to the discarded theory that it is primarily an organic physical condition. So this is quite interesting. So he's saying this in a time where psychoanalytic theory is dominant, where, somebody with schizophrenia, what they're doing is they're engaging in excessive wish fulfillment. They're caught up in a fantasy world. And, that's a psychological problem. And actually, prior to this, like 1899 or so, people were describing schizophrenia as dementia precox. So this is premature dementia. So that's kind of the idea that schizophrenia was a brain disease. And this, went away over time with psychoanalysis becoming the dominant sort of framework of thought for understanding mental health conditions. But then, LSD comes along and people are like, maybe we should go back to thinking about schizophrenia as some sort of biological condition, because here's a substance that people can take. And it seems to be producing some effects that are very bizarre and maybe somewhat psychosis-like. So why did people initially sort of say psychedelics are like psychosis? So in the early 50s, one of the first things that really brought this to people's attention is that people would experience visual hallucinations. The thing with psychosis is it's oftentimes primarily auditory, but still there's a lot of sensory disturbances. And, this is very unusual for a person's typical experience of, consciousness. So it seems like a fair assumption to make that, something that's a chemical that's causing these symptoms, maybe it's somehow related to schizophrenia. And then another factor to consider is that psychedelics seem to profoundly alter people's sort of thinking styles, creating a lot of confusion. This is a quote from a magazine at the time. And this person says it was confusing. Each idea I had became mixed with another. So kind of like a hyper associative frame of thought that in some ways sort of does parallel schizophrenia and psychosis, at least at the surface level. Here are these, we're giving people, it's like we're giving people, patients, we're giving a drug and they're experiencing all these very strong sensory disturbances, and their thinking is completely altered from what it is in everyday reality. That seems very strange. And the fact that it's active in such small doses sort of furthered people's interest in this drug somehow being relevant to psychosis. So this led to some ideas like the androchrome hypothesis. So this was the idea that basically a metabolic defect in people with schizophrenia was leading to a substance that was somewhat like mescaline to build up in people's bodies, causing them to basically be tripping constantly. And they saw, mescaline, oh, it's kind of like adrenaline. So, this must be some kind of biological issue. And then not so much with mescaline and androchrome, but especially with LSD, it being active in low doses was very interesting to people because they imagined, oh, could be something that's circulating around the body. And then another sort of bit of evidence in their mind at the time was that people with schizophrenia, when administered psychedelics, oftentimes they actually had a reduced response. So they could be given LSD, they could be given DMT, and they would trip less. One of those studies actually says that they were administering like up to 300 micrograms of LSD. So that's about 3 times the normal dose, and people weren't reporting much of a change. And this was found in both people with chronic schizophrenia and acute. So that's very interesting. And people at the time, how they interpreted that was that they had some sort of innate tolerance to psychedelics because they were experiencing them constantly due to this endogenous buildup. So they knew, the researchers at the time knew, oh, if you administer LSD multiple days in a row, you do see a tolerance effect in normal people. So maybe the reason we're seeing this reduced response was a tolerance issue. So that's not right. But I mean, you could see how somebody could think that and then say, oh, we're onto something with a biological basis of schizophrenia. It's not caused by something like, issues with your parents or, whatever psychoanalytic theory says about it. It's a biological issue. So that was very kind of groundbreaking at the time, pretty controversial considering what was going on in the rest of psychology. And this was really sort of Humphrey Osmond's his ideas about the main use for psychedelics early on, at least, was that they were useful models for creating a schizophrenic-like condition. So he said, schizophrenics are lonely because they cannot let their fellows know what is happening to them, and so lose the thread of social support. LSD 25, used as a psychotoma mimic, allows us to study these problems of communication from the inside and learn how to devise better methods of helping the sick. So to him, at least initially, the true value of psychedelics was to provide more insight into schizophrenia, to allow, people working in the mental health field to have more empathy with their patients, also to gain maybe a further biological understanding, but very different than what we hear sort of today about the main uses of psychedelics. And it's very interesting that this was what initially drew Osmond to studying LSD and androchrome and all of that, because he later actually coined the term psychedelic, which, as you might know, means mind manifesting or soul manifesting and all of this. So kind of a very different sort of interpretation, but at least initially, this is what drew a lot of people into studying psychedelics in the 1950s. So then the separate sort of idea that became prominent around this time was that psychedelics were somehow causing psychosis. And I think part of the reason that this might have come up a lot is that you think about if people think that schizophrenia is caused by a metabolic defect, and then you're adding more of a drug that's similar to what's being built up endogenously that's causing these psychotic-like symptoms, you could see how adding more of a similar substance might push somebody who has some of that substance built up over the edge. I mean, it doesn't quite fit with the whole, people with psychosis have a tolerance thing, but I think that, this idea that it's a metabolic buildup of something kind of influenced this, psychedelics must cause this idea. And sort of, if you look empirically at the rate of developing a psychotic reaction in people who use psychedelics, it seems to be very low. So one analysis found that in people who were healthy and given LSD, so this is 1,200 participants, doses ranging from 25 micrograms to 1.5 milligrams. So that's a huge dose. And out of all these people, there was only one psychotic reaction that lasted longer than 48 hours. So there's literally 1,000 dots on the first row, and then 200 dots below that. So that's kind of showing the rarity of how often this is occurring. So 0.8 people per 1,000 in healthy experimental volunteers. And, if you dig a bit deeper into what this person was like, you find something quite interesting. So this was a control participant, supposedly, for a study they were doing with people with schizophrenia. So he was an identical twin of somebody who had schizophrenia. And he was given 180 micrograms intravenously. And what happened to him, I'm not even sure today people would necessarily say it's psychotic. So according to the paper, during the initial experience, he was fine. He said there were some somatic disturbances and perceptual. That's to be expected with psychedelics. But then 2 days later, says he developed nausea, tension, a feeling of immobilization, anxiety, depersonalization, and preoccupation with a dream he had under LSD. He was then given barbiturates in a hospital, but he was fine 5 days later and returned to work. So that's not really as if he's developing something like schizophrenia. That's not a chronic long-term illness. And you don't see from this paragraph about this dude anything really suggesting that he was necessarily delusional, that he was experiencing auditory hallucinations, and some other hallmarks of, psychosis. It does sound like he was having an adverse reaction for sure, but is it really as if he's developing a psychotic disorder? Can't really tell from that paragraph. Of course, there are other examples of this. The literature from that time is it's a lot of the language that's used. It's so difficult to discern what's truly going on. So these are some examples of, one is an example of somebody who used a lot of psychedelics naturalistically. This person supposedly was going around saying it's a groove. He was interested in philosophical beliefs in Eastern religion, talked a lot about his LSD experiences, believed that, the world was cosmically determined, and had issues with depersonalization and visual hallucinations, and paranoid ideas as well. So there are some, maybe more psychotic features in that, paranoid ideas related to his internal feelings. But really, you couldn't take, the DSM criteria today and say, oh, this person sounds necessarily like he's developed schizophrenia or had a psychotic episode. It's just it's certainly interesting, but I wouldn't feel like you could diagnose somebody. And similarly with the other example, so a 25-year-old pre-schizophrenic latent homosexual with many neurotic fixations. So he was given 25 or 200 micrograms of LSD, and the schizophrenic features became more obvious, and he required hospitalization. The final outcome was not reported. So the language in that is quite strange, as you can see. Like, you wouldn't expect anything like this to be said in a journal today. Neurotic fixations, what does that mean? And also, according to this, it was a problem that he was gay or latent homosexual. We don't even know. So yeah, this kind of shows that we can't really make strong inferences off of these case reports from the 1960s about psychedelics necessarily causing psychosis. It does seem clear that some people can have very adverse reactions. They can involve, some paranoia, people behaving bizarrely, but is this really necessarily saying that somebody is developing schizophrenia? I wouldn't feel comfortable saying that it does. Another thing to think about is oftentimes the patterns that seem to produce this sort of psychotic, like, if you will, syndrome. So there's a fantastic paper. It's called Chronic Psychosis Associated with Long-Term Psychotomimetic Drug Abuse. And this paper details in a lot of depth 4 cases where people supposedly developed psychosis from using psychedelics a lot. And the use patterns that it describes are quite extreme. So somebody taking LSD almost daily, allegedly taking over 75 doses in 4 months. Another person during a 9-month period took 200 LSD trips. So you might know that typically psychedelics have less of an effect when used in close succession. The 5-HT2A receptors are so downregulated in the immediate post-acute effects that you supposedly have to take 3 times the dose or so. This is kind of like an anecdotal thing to get the same effects. So at that point, it's almost as if LSD maybe isn't acting serotonergically, but some of its sort of secondary, or at least based on the 5-HT2A receptor, but some of its secondary sort of binding affinities, like the D2 receptors, might be playing maybe more of a role in instances where people are taking 200 LSD trips in hardly any time. So who knows what's going on to do this? For somebody to be taking that many trips in that short of a time, they probably were quite strange to begin with. Psychedelics typically aren't drugs that create a pattern of abuse. So this is quite strange. Maybe they were trying to medicate in some way for an existing abnormality they had, and maybe they were trying to reduce their psychotic symptoms or something. Like, who knows? Like, this is not a typical case, these people. So that, to me, just again is another instance of how that older literature is very muddled, and we need to do more to sort of tease out the patterns. And we cannot simply say that because some of the sort of acute effects of psychedelics are like psychosis in some ways, that it's necessarily causing the condition. Another thing to think about is oftentimes people who use psychedelics will use other substances as well. And especially if somebody's using a lot of LSD, if somebody's taking 200 trips in a 9-month period, for instance, they probably are using cannabis. And a lot of those early case reports do suggest that people are using cannabis when they're developing these psychotic reactions from classic psychedelics. So this was a recent study that was looking at somebody's odds of developing a psychotic disorder and whether or not they're using high potency THC cannabis. And people who are using on a daily basis were approximately at 5 times greater the risk of developing a psychotic disorder. So, I mean, back in the 1950s and 60s, people didn't have access to the sort of high potency cannabis that is available today. But even when you're looking at, cannabis use that has less than 10% THC more than once a week, you're still seeing odds ratios greatly increase, So let's see, like 1.24, I think that says. It's not a ton, but it does add up. It is something to consider. It is a compound. So this kind of just goes to show when you hear of case reports, you need to consider this. People need to consider this as a possible large compound. So with sort of the history of psychedelics and psychosis saying, okay, maybe this is an endogenous or representing some sort of endogenous defect that people have that is leading psychedelics to build up. Then later on, people reported cases of people developing psychosis from using psychedelics, even though it was quite rare and it was compounded by a bunch of other drug use. What sort of happens next with people thinking about psychedelics and psychosis? Well, the next bit of research that goes on in the 1990s and 2000s really seems to kind of relatch on to the idea that psychedelics are somehow going to provide a biological insight into what's happening with schizophrenia. So we'll dive into some examples. So the first basically brain imaging study that other than with EEG that was done in humans was looking at mescaline, actually. This might be kind of surprising to people given that we don't have any fMRI studies of mescaline at the moment that I'm aware of. So this study was seeing if mescaline was inducing psychopathology and whether or not this might provide some sort of insights for psychosis. So this was using SPECT, single photon emission computed tomography. It's not very often used anymore, but was some of the best technology at the time. And in a sample of 12 people, all men, they found that mescaline seemed to produce something they called hypofrontality. So the frontal parts of the brain were more active, and these correlated to psychotic symptoms. But they were only giving their participants pretty much questionnaires related to psychosis. So brief psychiatric rating scale, paranoid depression scale, the altered states of consciousness scale was kind of created with an idea that you were capturing alterations in consciousness that were similar to psychosis. And so, yeah, they found that the frontal lobe correlated to these psychotic symptoms. And this is very curious because the main sort of narrative at the time in schizophrenia and psychosis research was that people with schizophrenia often display hypofrontality, so reduction in frontal lobe activity. So they saw this and they say our findings question this assumption about schizophrenia. It seems a bit bizarre to make that leap, that you're seeing a difference in brain activity, but yet, there are some symptom overlaps. So you're saying that, oh, some of that schizophrenia research must be wrong, and we're going to learn more about psychosis from seeing what it does with a drug effect, which doesn't seem to be similar in the brain. Kind of strange logic, in my opinion. But okay. It's still a very groundbreaking study, I think, for the time. Then a few years later, in 1997, there was a positron emission topography study that was looking at glucose metabolism under psilocybin. And it also found that there was an increase in glucose metabolism. So that's saying those regions of the brain were more active. So this was particularly, according to them, in the frontal medial regions, in the frontal lateral cortex, anterior cingulate, also temporal medial cortex. Again, a pretty small sample. And if you just read this paper, you'll see that it's very much from the lens that, psychedelics, psilocybin is somehow producing a model of psychosis. That's the assumption that they're going on. It's producing a psychotoxic syndrome, according to them. And the questionnaires that they gave people, again, were very much focused on sort of pathological traits. So they gave their participants ego pathology questionnaires. So ego identity impairment, ego demarcation, ego consistency, ego activity, and ego vitality. To me, it's a bit curious that this is initially where they're going. Ego being a psychoanalytic term, given that psychedelics were initially sort of related to psychosis because people were saying, oh, this is showing that there could be a biological basis, that it's not psychoanalytic in origin. So it's just a bit curious to me that this is where they initially sort of take it. And it's also kind of paving the way for future theories and studies of psychedelics to take a neuropsychoanalytic bent, if you will, because this is kind of the language that they introduced into the field. And the same team of researchers, or largely the same team, they also did a study where they administered antipsychotics to people before psilocybin, so a pre-treatment with it. And they wanted to see, is this going to reduce the psychotic symptoms that people experience? So they gave people a 5-HT2A antagonist, ketaracine, and this substantially reduced the effects to almost placebo, you can see, when people are given the largest dose. And risperidone is an atypical antipsychotic that has some 5-HT2A antagonism with D2 antagonism as well. And this also substantially reduced people's psychedelic experience. But then they also gave people haloperidol. Haloperidol is a typical antipsychotic, and it's a D2 antagonist. And it actually, funnily enough, seemed to increase people's experience of anxious ego dissolution. So it's increasing the psychotic-like effects. That's very strange, that an antipsychotic makes supposedly psychotic symptoms worse. So they kind of interpreted this to mean that, we should look more carefully at 5-HT2A receptor dysfunction and see if that's related to psychosis somehow. They didn't really phrase their paper in such a way where they were saying, oh, well, this is showing maybe that psychedelics aren't like psychosis, given that, we can give somebody an antagonist that's typically effective for treating psychosis, and it doesn't seem to reduce symptoms. It seems to make them worse. Again, some strange logic, but people are persistent with the idea that psychedelics must be telling us something about psychosis. So yeah, this slide is kind of just reiterating that point, that antipsychotics really aren't the opposite of tripping per se. So they've done studies where they look at sort of the therapeutic efficacy of both typical and atypical antipsychotics. And even though atypical antipsychotics, these are the modern ones that are most commonly used, do display a lot of 5-HT2A receptor antagonism, their therapeutic action, their ability to reduce positive symptoms seems to be correlated most strongly to their D2 receptor antagonism or inverse agonism. So that's quite different than saying, oh, these drugs, they must be the opposite of psychedelics because they display 5-HT2A antagonism. The thing about that is it seems that that 5-HT2A antagonism that's often found in atypical antipsychotics is it seems to be important for probably reducing some of the side effects, not necessarily contributing that much to reducing psychotic symptoms. They've done studies with 5-HT2A antagonist, pure ones, in people with schizophrenia, and it's not effective. So that argument that, oh, psychedelics are implicating that the 5-HT2A receptor is very strongly involved in psychosis, the logic there isn't quite that strong, in my opinion. So another sort of idea or theoretical framework that came out of this research that was very groundbreaking at the time with, the PET and the SPECT-based studies is this idea of thalamic gating. So, people will say that, psychedelics, they open the reducing valve of consciousness or whatever. I believe that's a Huxley quote. People seem to kind of have latched on strongly to this idea. So when trying to explain how hyperfrontality was found with those PET and the PET and SPECT-based studies, they said, oh, maybe the thalamus is reducing its filtering, and this is somehow leading to the cortex, the prefrontal areas especially, to become overactive. And maybe this is subjectively experienced as an information overload. And when there's an information overload, what happens? Ego dissolution. Supposedly. You can probably see that there are several jumps in logic going on here. You find that this hypofrontality, it correlates to psychotic symptoms, supposedly. And then you're assuming that that is what's causing ego dissolution. You don't necessarily know. It could just be a general signal of drug effects. But this theory was created, and it seems to pick up on some things that are important to psychedelic science to understanding their effects. So there's a sense of information overload, and there's something going on with people's sense of self that is just off. So in the 2010s, some work came out that started contradicting those early studies with mescaline and psilocybin. So there was a bold, I think it was bold. Well, there was an fMRI study that found a reduction in brain activity in the prefrontal cortex. And, a lot of studies showing, oh, there's a decrease in default mode network connectivity. All these studies showing that there is a reduction, so that people are like, oh, it's the inverse of, what you're seeing with the hypofrontality reported early on. But yet these papers also make the claim that this is somehow like psychosis, that there is, a reduction in default mode network connectivity in schizophrenia. And basically it still holds this hypothesis that somehow the neuroscience, or this bias, that somehow the neuroscience of psychedelics is telling us something about psychosis without ever really proving up front that the symptoms and the experiences that people are having are that related. Still relying very much on assumption. So yeah, you might say, oh, there's two contradictory neuroimaging results. What's really going on in the brain? Well, it's hard to tell with sample sizes of 12 or 15. But I think a bigger problem is that these are different modalities. And it's been shown that, you can't really correlate glucose metabolism, particularly in the default mode network, with bold signal. So that's another issue. They're often not tightly correlated. So there's that there's that methods issue. But again, we're seeing this influence of psychedelics being compared to psychosis in some ways. Again, with the Freudian sort of framing, which is interesting, given that initially psychedelics were like psychosis to people for biological reasons, supposedly, that were supposed to kind of say, oh, something separate than what psychoanalysis can explains schizophrenia. So again, very interesting. And you can really see how this trend of comparing psychedelics to psychosis has influenced some of the most influential theories of explaining how psychedelics work. So like the entropic brain theory, that is comparing psychedelic states and psychosis partially. There's supposedly a reduction in high level priors in both experiences, as explained by Rebus. The default mode network, it's altered in both psychedelic states and psychosis. Again, it just kept going and going and going. So very influential, but people, I think, fail to recognize how the whole psychedelic psychosis assumption came to be. So the entropic brain model. Okay. So self-entropic broadening theory. Yes, it's obviously influenced in part by this model. So what does the entropic brain model say? Well, most basically, the idea is that neural entropy correlates to an increase in richness of the conscious experience. So according to this theory, psychedelic states and psychosis and meditation are states that have a higher level of information richness to them subjectively, and also supposedly have a higher level of neural entropy, supposedly. And then on the opposite side of the continuum, supposedly in low entropy states, and states where people have a sort of poor qualia of experience, that there is a decrease in brain entropy. So according to the original model, this would be things like addiction, depression, a coma, and anesthetized states. I think a lot of the ideas presented in this model are very interesting. The idea that the richness of experience is very important to both psychedelic states and psychosis. The idea that there is something sort of chaotic and unpredictable going on in the brain, but I think a lot of the sort of comparisons that are being made are quite difficult. So let's look at like high entropy states. Is a state of mindfulness like a state of psychosis? Is a state of being addiction like coma? Are there commonalities? Or are there distinctions? So yeah, self-entropic broadening theory kind of takes some aspects of this model and kind of reworks them to kind of, I think, take the best sort of points. So there's a lot going on with this whole psychosis and psychedelics discussion. There are bits and pieces of ideas that are very different from each other, that are kind of floating around and chaotically interacting with each other. There's, the metabolic hypothesis. I don't think anybody really thinks that, but I still think, it's led to the idea that, oh, we're going to learn something about the biology of schizophrenia from studying psychedelics, which, why do we think that's the case necessarily? Does it have to be? And then there's the whole idea that psychedelics are somehow a risk factor for psychosis. I mean, that makes sense if you're in the 1950s and you think this is a metabolic defect and you're giving people basically something that's just like the metabolite that causes schizophrenia. That makes sense to make that assumption. But can we make that assumption now? And then there's all these ideas about brain entropy, the default mode network being off, and that's somehow related to ego dissolution and information richness. There was this thalamic filtering hypothesis, and hyperfrontality. Both of these sort of schools of thought, whether people regularly acknowledge it or not, are very much influenced by sort of psychoanalytic ideas. Oh, people's egos must be off in both experiences or whatever, even though initially what drove the comparison, at least primarily, was this idea that psychedelics are useful because they're showing that schizophrenia is not something that's due to ego trauma, or that's probably not even a real psychoanalytic term, but something like that. They're showing that there is a biological basis. So, as you can see, the field is kind of in a mess of ideas, and there's a lot of unquestioned assumptions and connections. But I think sort of some of the core building blocks, I guess you could say, that do keep coming up is that both psychedelic states and psychosis produce sensory alterations, okay? That's pretty apparent. People are hallucinating, whether it's a real hallucination or a pseudo hallucination, that does seem to be shared. You could maybe say both states are more information rich. That it's kind of an idea shared by both the thalamic filtering theory, and the entropic brain, that somehow experience with psychedelics is more rich. And somehow this is sort of similar with psychosis, that experience is more intense. And that there is alterations in self-experience with both psychedelic states and psychosis. You see that with both thalamic theory and thalamic gating theory, and the entropic brain, rebus, those sorts of theories. So I think those are some good building blocks to take away from this sort of hodgepodge of ideas. And I think it's important to sort of acknowledge that unless you're living in a world where psychedelics are producing psychotic-like symptoms because they're like a metabolite, which there's no evidence for, that something being a risk factor and something mimicking are separate questions. Cannabis acutely, it's not producing as many sensory disturbances as psychedelics, but yet it seems to be a very strong risk factor for developing a psychotic disorder when there's a high THC content. So that's quite, that's just one example of how you can't really compare mimicking and inducing. So those are some core building blocks to take away. This kind of, I suppose this talk in a lot of ways just shows how much confusion there is around this whole question of psychosis and psychedelics. But I think it's good to sort of acknowledge what has been historically sort of influential and what ideas have kind of floated about. So yeah. By just perpetually saying, oh, we should be excluding people from trials who have a family history of psychosis or a personal history, by continuing to say that psychedelics are somehow, informing schizophrenia research, and not really like seeing how did this get to be something that people were saying. There's a lot of unexamined assumptions, as I've said repeatedly, that could lead to bad science. So I think it's good to try to take the best ideas or the most kind of enduring ideas from all these different lines of evidence to maybe create a new paradigm that can be tested, and might inform this question further. So that's what I tried to do with self-entropic broadening theory. It is very much a model. It is very much not right about some things, I'm sure, but hopefully it will prove useful for guiding further empirical research, or at least that's what I tried to do. So that's the sort of primer for self-entropic broadening theory. And if you have any questions about what was presented today, you can contact me via email or Twitter. And that is all.